This is hematology, especially coagulation disorders relevant to the pediatrics board exam. This slide will cover the summarized version of the coagulation cascade. On the left, you can see the intrinsic pathway, which involves factors 8 and 9. Those are the hemophilia factors, an intrinsic pathway. And then it also involves 11 and 12. So 4 factors, 8, 9, 11, 12. We skip 10 because 10 is in our common pathway in the center. We have 5, 2, and 1. So 4 factors in the intrinsic and common pathways. Intrinsic was 8, 9, 11, 12. Common is 1, 2, 5, 10. And then on the extrinsic pathway, we just have factor 7. For the intrinsic pathway, 8, 9, 11, 12, we use PTT. For the extrinsic pathway, 7, we use PT. So an important thing to note is that factor 1 is also called fibrinogen. That was one of the first factors in the common pathway. So when we're screening for coagulopathy, as I mentioned, you use PTT to screen for the intrinsic pathway, and then this will also pick up deficiencies in the common pathway. So to recap, intrinsic was 8, 9, 11, and 12. And then common pathway was 1 or fibrinogen, 2, 5, and 10. You would use PT to screen for problems in the extrinsic pathway, 7, or the common pathway, fibrinogen, 2, 5, and 10. If you have an abnormal PTT, that suggests that there's an issue with the intrinsic. If you have an abnormal PT, then that suggests that it's a problem with the extrinsic for PT. If both the PT and PTT are abnormal, then that suggests a problem with the common pathway. It's what's in common between them. If your PTT and your PT are both normal, but you have bleeding problems, that would suggest something outside of these pathways, like a factor 13 deficiency, a platelet disorder, or von Willebrand disease. When you're screening with these two tests, it doesn't tell you the risk for bleeding. It can have false positives, and this test is affected by factor inhibitors if you don't use a mixing study to detect the inhibitors. Lupus anticoagulant is the most common factor inhibitor. It usually will prolong the PTT, but it also can prolong the PT. So this factor inhibitor doesn't correct with a mixing study, so it causes a little bit of problems for detecting it. It's typically caused by a viral infection, and it can be transient or asymptomatic. When we're using the mixing studies for other factor inhibitors, we combine half of the solution is patient plasma, and then half of the solution is normal plasma with all the factors present. So if you're suspicious that the patient has a factor deficiency, you're picking up an abnormal PT or PTT, or you're not sure if it's a factor deficiency or an inhibitor, when you add the normal plasma, if it was just a factor deficiency, then that PT or PTT should correct because the deficiency is no longer present. But if you combine the normal plasma that you know has all the factors and it still doesn't correct, then there's a factor inhibitor present that's acting on the normal plasma alike. Some specific factor deficiencies: hemophilia A is caused by factor 8, and then hemophilia B is one step up from that on factor 9 deficiency. These hemophilias are X-linked, so girls will typically only be carriers, and then it will just be boys that are affected. It can present with bleeding in infancy, like intracranial hemorrhage or excessive bleeding with circumcision. And then in older children and toddlers, we'll see these deep bleeds of bruising and hemarthroses. Most commonly, these affect the ankles, knees, and elbows. Sometimes patients will present with something that looks like more abdominal pain or femoral nerve compression or paresthesias. You would scrutinize the iliopsoas, which is a common bleeding site for hemophiliacs. The PTT would be prolonged for these factor deficiencies, and the PT is normal for the hemophilias. Why is that? PTT was testing our intrinsic pathway, which was 8, 9, 11, and 12. And then our PT is normal because that's our extrinsic pathway, just factor 7, which is not affected by hemophilia. And then there's no inhibitor present, so for hemophilia, it will correct with a mixing study. You treat patients with hemophilia as needed for bleeding symptoms with factor replacement. So you'd replace factor 8 for hemophilia, factor 9 for hemophilia B. And then you can also do prophylaxis if they're needing it frequently, up to 2 to 3 times per week. So in addition to hemophilia A and B, there's also a hemophilia C, which is a factor 11 deficiency. So if you think about the intrinsic pathway, 8, 9, 11, 12, hemophilia A was 8, 9 was B, and then we skip 10 because that's in the common pathway. Hemophilia C is in factor 11. There's also a possibility for factor 13 deficiency. Factor 11 and factor 13 deficiency are autosomal recessive, and they're associated with Ashkenazi Jews. Factor 11 deficiency or hemophilia C might present with post-traumatic or surgical bleeding. Factor 13 deficiency, similarly to the other factor deficiencies, can present in infancy with intracranial hemorrhage and with umbilical site bleeding. Vitamin K deficiency. So vitamin K is one of the fat-soluble vitamins, A, D, E, and K, and there's limited stores at birth, so we typically supplement with this in the delivery room. Classic vitamin K deficiency will present at 2 to 7 days, and we would just replace the vitamin K. If it's presenting earlier, like on day 1, then we would think about mom's medication, so warfarin and seizure meds are common ones. And then if it's presenting late with vitamin K deficiency, then that would be at like 1 to 6 months. We think about malabsorption, liver disease, or chronic antibiotics use. Vitamin K deficiency presents in infants with bruising, intracranial hemorrhage, GI bleeding, and umbilical bleeding. We would give the normal vitamin K supplementation, like I said, for classic presentation, and then if it was late, then we would use IV vitamin K. With vitamin K deficiency, all of the vitamin K dependent factors will be low. So these are 2, 7, 9, 10, and protein C and S. Since these factors are involved with both the intrinsic and extrinsic and common pathways, with vitamin K deficiency, you'll have a prolonged PT and PTT. Von Willebrand disease, this is the most common inherited bleeding disorder. Von Willebrand factor is a carrier for factor 8. It binds to collagen at the site of any kind of vascular injury and then starts binding the platelets. When you have increased stress or pregnancy, or you have more ADH or GDAVP administration, then the von Willebrand factor will increase. Type 1 von Willebrand disease, which is autosomal dominant, you have decreased von Willebrand factor production. So with von Willebrand disease, it's a factor deficiency, similar to the other problems. With type 2, this is also autosomal dominant, your production of von Willebrand is fine, as was the problem with type 1, but the function of von Willebrand factor is decreased. There are some subtypes of type 2, which is the functional issues. 2A, they have absent large multimers. 2B, it's just too sticky, so you may see thrombocytopenia when the platelets are binding too much. 2M subtype has poor binding, and then 2N binds platelets okay, but it doesn't bind the factor 8. Finally, type 3 von Willebrand disease is autosomal recessive, and this is a complete absence of the factor. So type 1 was decreased production, type 2 was decreased function, type 3 is complete von Willebrand factor absence. Von Willebrand disease will present with mucocutaneous bleeding, bruising, nosebleeds, oral bleeding, menorrhagia, and postpartum or post-surgical bleeding. So similar bleeding symptoms to the other factor deficiencies that we discussed, but more kind of oozy mucocutaneous bleeding and then problems with periods. We would test for von Willebrand disease with the von Willebrand factor antigen level, and then we can use the activity or the ristocetin cofactor test to test for the function. So the level test will tell you type 1 or type 3 issues, and then the function test, the ristocetin factor test, would help you know if it's type 2 von Willebrand disease. And then you can also check for multimer levels, which would be type 2, but also would check for essentially all the levels of von Willebrand. We treat von Willebrand disease with DDAVP because, like I said, that will increase the levels. We can just replace the von Willebrand factor and factor concentrate. We can use antifibrinolytics, which are clot stabilizers. These would be things like TXA and aminocaproic acid. We can also treat with estrogen and hormonal contraception because, like I said, von Willebrand disease factor increases with pregnancy. A 7-year-old girl has obstructive sleep apnea, enlarged tonsils, and needs a tonsillectomy. You order a PT and a PTT. The results show a PT of 11.5 seconds, which is normal, and a PT of 37.6 seconds, which is just outside the normal range of 25 to 35. She has no personal or family history of bleeding. Which of the following statements is most likely to be true regarding this patient? She has hemophilia A, she has von Willebrand disease, she has a transient coagulation inhibitor, the result is likely a false positive and can be ignored, the results are close enough to normal and should be disregarded. So we shouldn't ignore any positive results, especially when we're getting ready to do a surgery. So the last two answers, the result is a false positive and can be ignored, and that they're close enough to normal and should be disregarded, we can rule those out. Does she have hemophilia A? This is unlikely. She has no bleeding history, and she's a girl, so hemophilia A she could be a carrier for, but she's unlikely to actually have the disease. Second answer choice was she has von Willebrand disease. This is possible in a girl, but she doesn't have any bleeding history. So then the last one that's left over is that she has a transient coagulation inhibitor. We talked about how these can be asymptomatic from a recent viral illness, and this goes along with her vignette a little bit more than her having von Willebrand disease. A 13-year-old boy with a history of moderate hemophilia A is brought to the emergency room by his mother. He's complaining of pain near his right hip after playing soccer with his friends. He is unable to extend his right hip fully. What is the next best step? Give the patient an infusion of factor VIII product. Get a stat x-ray of the bilateral hips. Get a stat CT of the abdomen and pelvis. Get a stat CBC, PTT, and factor VIII level. The correct answer is to give him an infusion of factor VIII. We know that he has hemophilia A, and he's got obvious bleeding signs. We're concerned about that iliopsoas bleed. So we would give him replacement of that factor to stop that bleeding. The other answer choices are more diagnostic and would confirm your diagnosis, but we want to stabilize the patient first. So now we'll move to platelet disorders. We can separate these into two subcategories: quantitative platelet disorders like decreased numbers, and then qualitative like problems with their function. The quantitative platelet disorders, where the numbers are down, we see decreased production in thrombocytopenia absent radius, so TAR, and then in Wiskott-Aldrich syndrome. So production is one of the quantitative types, and then destruction is the other quantitative type. So these are the immune types of platelet disorders. So we have the neonatal immune thrombocytopenia, we have immune thrombocytopenia that's not neonatal, so just ITP, and then there's HIT, heparin-induced thrombocytopenia. And then the qualitative ones are Glanzmann's thrombasthenia, and then Bernard-Soulier. So we'll talk about the quantitative ones first. So TAR syndrome, This is thrombocytopenia absent radii. This is autosomal recessive. These patients need platelet transfusions because they don't produce platelets, and typically the thrombocytopenia will resolve after 1 year. So once they're no longer an infant, then we start seeing that this is getting better, but they'll still have the absent radii. Wiskott-Aldrich syndrome is X-linked recessive. This presents with thrombocytopenia, small platelet size, eczema, and immunodeficiency. They have a specific immunodeficiency for opportunistic infections like PCP, molluscum, varicella, and CMV, and then to antigens that have polysaccharide capsules like strep pneumo, Neisseria meningitis, and H flu. So now within the bucket of problems with numbers, we have, separately from problems with production, problems with consumption. So destructive platelets. So the first diagnosis is neonatal alloimmune thrombocytopenia, or NAIT. This is when the mom has antibodies against the fetal platelets. We think about the HPA-1A gene for this diagnosis. These babies are at risk for intracranial hemorrhage. We would diagnose them by genotyping the mom and the dad, because the dad may have the antigens that the mom's antibodies are against, and then we would treat with platelet transfusions of the mom's platelets because those antibodies won't attack those, or HPA-1A negative platelets because that HPA-1A is the common antigen that the mom is fighting against. Immune thrombocytopenic purpura, we can think about bruising, petechiae, nosebleeds in the vignette. ITP is typically preceded by a viral infection or other immunization. The patient will create antibodies against their own platelets, so IgG against the GP2B3A, so GP2B3A or 1B9, and then we'll have just isolated thrombocytopenia in ITP. So if you have other cell lines down, you would think about a different diagnosis. So you don't need marrow testing for ITP. For ITP, it's self-limited. We can probably just observe patients with ITP. If you give extra platelets, then they will just keep consuming them. So if you really need to stop the consumption, you may give steroids, IVIG, anti-D immunoglobulin, but anti-D immunoglobulin has a risk for hemolysis. Complications of ITP include intracranial hemorrhage, immune suppression from the steroids, or if this patient autoinfarcts their spleen. Aseptic meningitis can happen from IVIG, or progression of ITP to chronic disease. So the last of the penias, or problems with numbers in thrombocytopenias, is HIT, which is another consumptive or destructive process. The name is a little bit of a misnomer. It should be called heparin and other medication-induced thrombocytopenia, because this can also be induced by analgesics, anticonvulsants, antimicrobials, blood pressure medications, and H2 blockers. We typically will see the effects of the medication about 5 to 14 days after the exposure, or acutely if we're re-challenging it. The antibodies that are present are the heparin PF4 antibodies. We'll see mild thrombocytopenia, predisposition to clot formation, and we would diagnose it with a serotonin release assay, which is a marker for platelet activation. We would discontinue the insulting drug, and then we would use argatroban, and then it's important to note that we wouldn't use warfarin or low molecular weight heparin. So low molecular weight heparin or enoxaparin, and then warfarin because of the risk for skin necrosis. So now we'll move on to the qualitative platelet disorders. These are the problems with the platelet function. Glanzmann's thrombasthenia is the first diagnosis to talk about. This is autosomal recessive. the patients don't have the GP2B3A, so they can't bind fibrinogen and then they can't aggregate. They will present with mucosal bleeding because those platelets can't aggregate at the site of rapid cell turnover. You would test with platelet aggregation testing. If you use the ristocetin test to test this patient, which you might be testing for von Willebrand disease with ristocetin, this would be normal with Glanzmann's. You would treat with factor 7, platelet transfusion, and more definitive cure would be a stem cell transplant. Bernard-Soulier syndrome is also autosomal recessive. These patients will present with mild thrombocytopenia. The buzzword for Bernard is large platelets and then more severe bleeding. They also have a GP problem, but this is the 1B9 von Willebrand factor connection, so they can't bind on the endothelial sites. This test would also have abnormal platelet aggregation, but because of the involvement of that von Willebrand factor, you would also have an abnormal ristocetin test. So ristocetin is abnormal with Bernard-Soulier and then with von Willebrand disease because it's looking for that von Willebrand factor function. You would treat Bernard-Soulier with platelet transfusions. A 4-year-old boy has many bruises on his legs and petechiae. The remainder of his exam is normal. Platelet count is 12,000, but he otherwise has a normal CBC and coags. Some of the platelets on the smear are large, which is true about this disease. It is most prevalent in Ashkenazi Jews. A platelet transfusion is indicated if the patient's platelet count is less than 20,000. It's usually preceded by a malar rash. 100% of cases will spontaneously resolve within 1 year. Steroids can be started for treatment without a bone marrow biopsy. So we have a 4-year-old boy who's previously healthy and he has bruises and petechiae, but nothing else on his exam. He's got thrombocytopenia, but normal coags and normal CBC. So we can rule out hemophilia for this patient who has normal CBC and coagulation studies. We can rule out other types of cancer because there's only isolated thrombocytopenia and with the normal CBC. Some of the platelets on the smear are large. That is a red herring here for Bernard-Soulier. If we were worried about Bernard-Soulier in this patient, we would have much more significant bleeding and we might have other abnormal exam findings like mucosal bleeding. So this patient has ITP because of his isolated thrombocytopenia and petechiae. The answer choices, it is most prevalent in the Ashkenazi Jewish population. This answer choice is getting at hemophilia C or factor 11 deficiency and factor 13 deficiency. A platelet transfusion is indicated if the patient's platelet count is less than 20,000. If you transfuse platelets for a patient who's going through an ITP, then they will just continue to consume those platelets. It's usually preceded by the appearance of a malar rash. This is incorrect. It's immune thrombocytopenia, but it's not an autoimmune condition that has a malar rash like lupus. So it's usually preceded by a viral syndrome like a URI or stomach bug. The next answer choice, 100% of cases will spontaneously resolve within 1 year. This is true for 90% of cases, but a complication of ITP is progression to chronicity, which occurs for 10% of patients. And then that just leaves the last answer choice. Steroids can be started for treatment without a bone marrow biopsy. Since we have that normal CBC, we don't have to worry about other cell lines being down. We have isolated thrombocytopenia. If our platelet count was coming down low enough that we were worried he needs a transfusion, we should instead start steroids to stop that consumptive process. A newborn male is noted to have multiple congenital anomalies, including bilateral renal agenesis, hypoplasia of the middle phalanx, and an ASD. He has thumbs. His platelet count is 27,000. Which of the following is true regarding TAR or thrombocytopenia absent radii? A, it's associated with a chromosomal translocation. B, thrombocytopenia will usually spontaneously resolve after 1 year. C, platelet transfusions are not helpful to treat bleeding in the presence of thrombocytopenia. D, most patients with TAR have a known family history. And the E, life expectancy is significantly shortened due to bleeding in the second decade of life. The correct answer is that for thrombocytopenia absent radii, the thrombocytopenia will usually spontaneously resolve after 1 year. The first answer choice that it's associated with translocation is incorrect. It's associated with the RBMBA gene and a mutation in that gene. Transfusions are the mainstay of treatment, so the answer choice that platelet transfusions are not helpful is more applicable to ITP, like our previous question. The other answer choice, life expectancy is significantly shortened, is incorrect because usually they just have bleeding in the first year and then they have a normal life expectancy. And then most patients with TAR have a no family history. This is incorrect. The inheritance pattern is not clear, but usually TAR patients don't have other family members that have this. So now we'll talk about coagulation disorders that can occur in life that are not congenital. So hemolytic uremic syndrome, or HUS, this peaks in young children ages 6 months to 4 years old. We'll see a triad of symptoms: hemolytic anemia, thrombocytopenia, and acute renal failure. So anemia and thrombocytopenia separate, to contrast from those isolated thrombocytopenia disorders that we had with before, and then kidney problems and anemia. We might see the presence of schistocytes, which you can see on the path smear on the right, which are red blood cell fragments. This occurs because the Shiga toxin from E. coli damages the vascular endothelium, and then that inactivates the ADAM antigen, which causes problems for platelets. Von Willebrand factor multimers form and then start activating platelets, and then the microthrombi cause microangiopathic hemolysis. We can see bloody diarrhea, hematuria, kidney failure, and hypertension related to the excessive bleeding from the thrombocytopenia and the GI bleeding, and then the kidney problems because of those microthrombi, and then the kidney problems can cause high blood pressure too. The other coagulation factors should be normal, your fibrinogen, D-dimer, PT, and PTT, because there's no factor deficiencies. We would treat with dialysis, transfusion, antibiotics. Sometimes these HUS patients are self-limited, but about 10% will go on to develop chronic kidney disease or end-stage renal disease. So to contrast with HUS, a different acquired coagulation disorder is TTP, or thrombotic thrombocytopenic purpura. TTP looks a lot like HUS. It has the triad of hemolytic anemia, thrombocytopenia, and acute renal failure. But TTP also has fever and neurologic symptoms, so it's a pentad instead of the HUS triad. TTP can be from an autoimmune condition, cancer, pregnancy, medications, HIV. It's the same pathway as HUS, where there's an antibody that inhibits the ADAM TS13, and you'll also see large von Willebrand factor multimers for TTP. The neurovascular changes are from microclots in the brain, and this has a 95% mortality rate, so we need plasmapheresis to remove that ADAM inhibitor. Finally, we'll talk about DIC, or disseminated intravascular coagulation. This can be caused from infections, leukemia, trauma, burns, liver disease, or snake bites. And then we have a pathologic coagulation activation. So issues with sepsis and then small clots that start consuming your platelets. You'll see a decreased fibrinogen, but a high PT, PTT, and D-dimer. You may also see schistocytes on the smear. We would want to reverse the underlying cause, give cryo, FFP, or platelets as needed. So both HUS and DIC can have schistocytes, but DIC will look more like sepsis and HUS will look more like thrombocytopenia, anemia, and kidney problems. In general, when a patient is bleeding, especially if you don't know the diagnosis, fresh frozen plasma or FFP is going to replace all the factors. Cryo will replace fibrinogen or factor 1. Platelets will correct most thrombocytopenias except for those immune ones. Those were neonatal alloimmune thrombocytopenia and ITP. And then if you use factor 7, you can use this as a bypassing agent for emergency hemorrhage. That's your extrinsic factor. So now we'll talk about thrombotic disorders. Protein C and S, these are natural anticoagulants. So activated protein C or APC inactivates factor 5A and factor 8A. And then protein S is just a supplemental cofactor for APC. So S is like a sidekick for protein C, which is an anticoagulant. Both protein C and S are vitamin K dependent. So if you have a vitamin K deficiency, then protein C and S will also be deficient. If you have isolated protein C or S deficiency, this will look like thrombosis from excessive clotting, DVTs, neonatal purpura fulminans, which presents with bruising, skin necrosis, and looks like DIC. You would treat deficiency of protein C and S with FFP, and these patients often need long-term anticoagulation to prevent those clots. Similarly to protein C and S deficiency, a patient who's deficient in antithrombin 3 may also have issues with too much clotting. So we've come kind of full circle from hemophilias, like we talked about, to excessive clotting. Antithrombin 3 deficiency may present with patients that have nephrotic syndrome and in patients with protein losing enteropathy. They're losing these proteins through either the gut or by excreting them in nephrotic syndrome, and so they're losing that protein of antithrombin 3. These patients will be resistant to heparin, so they're clotting and you're trying to anticoagulate with heparin, but heparin works by increasing the effects of AT3, which they're deficient in. We would treat them with some other type of anticoagulation if they're with AT3 deficiency, or just replace the AT3 concentrate. Virchow's triad of thrombosis is blood vessel abnormalities. So if a patient has IV catheter put in and that causes problems with the vessel, you may see thrombosis when there's alterations of the blood constituents, so the deficiencies that we talked about, or in cases of sepsis, shock, malignancy, estrogens, or heparin-induced thrombocytopenia. So vessels, constituents, and then the flow of the blood. So if you have a large bore catheter where the blood is more static, patients who are immobilized, patients with vascular malformations, or patients who have undergone surgery, that can predispose patients to thrombosis. Inherited thrombophilias include factor V Leiden mutation, prothrombin mutation, the MHTFR, it looks like motherfucker, but it's the MTHFR mutation with high homocysteine, and then the protein C, S, and AT3 deficiencies. You can also see problems with a thrombophilia or thrombosis, more clotting, with antiphospholipid antibodies and ATC deficiency. When we're trying to anticoagulate these patients, so we've gone from hemophilias where the patients are bleeding too much to then problems with like protein C and S and AT3 causing too much clotting and things like DVTs and PEs. So when we want to anticoagulate patients, we would use heparin, which binds AT3 to help inactivate 10A and the thrombin. We would monitor heparin with PTT and the anti-10A level, and then we reverse heparin with protamine if we start getting too much bleeding. Enoxaparin, which is low-weight molecular heparin, is the same as heparin, but it mostly inactivates 10A instead of the AT3. We would monitor low molecular weight heparin with the anti-10A level, but not with the PTT that we did with heparin. And then similarly, we reverse with protamine. We would be nervous about using low molecular weight heparin in patients with kidney disease. So just use heparin if there's kidney disease. Warfarin inhibits vitamin K reductase to decrease the vitamin K dependent factors. Those were 2, 7, 9, and 10. When you use warfarin, it will cause a transient hypercoagulation, so more clotting with the initial part of warfarin before the anticoagulation effect. This is because of inhibition initially of protein C and S when you start warfarin. We would monitor warfarin use with INR and then reverse it with FFP and vitamin K. The side effect to look out for with warfarin use is skin necrosis. So just to zoom out again, talking about many of the disorders that we've talked about throughout this video, X-linked disorders were hemophilia A and B, because they're only in boys, and then Wiskott-Aldrich, which is X-linked as well. So you're only going to see these in boys. Autosomal dominant diseases were protein C and S deficiency, and then von Willebrand disease type 1 and type 2. Type 1 was the issue with production is decreased. Type 2 was the issue with the factor function for von Willebrand disease. Type 3, which is autosomal recessive, was an issue where you have absolutely no production of von Willebrand factor. Other autosomal recessive diseases are the factor 11 deficiency that we talked about with Ashkenazi Jews, and then Glanzmann's thrombasthenia and Bernard-Soulier. Those are all autosomal recessive. A 3-year-old boy is diagnosed with severe hemophilia B after presenting with hemarthrosis of the left ankle. Which of the following is true regarding the inheritance of hemophilia B, which is factor 9 deficiency? A, an affected male has a 50% chance that a daughter will carry the mutation. B, a carrier female always has a father with the disease. C, the son of an affected male can never have the disease. D, an affected male and carrier female have a 25% chance of having a normal daughter. Or E, a carrier female has a 50% chance of having an affected son. The correct answer is that a carrier female has a 50% chance of having an affected son. So the carrier female carries this hemophilia B on one of her X chromosomes. She has to pass her X chromosome to her son because the son is going to get the Y from the dad. So one of those two X chromosomes that the mom is carrying hemophilia B on is going to pass down to the son. Let's talk about the other answer choices. An affected male has a 50% chance that the daughter will carry the mutation. Hemophilia B is X-linked recessive. So if you have an affected father, he has XY, and the X is going to go down to the daughter. That one is with hemophilia on it if he's affected. So the daughter has to carry the mutation because she has to receive one of those X's from her dad. The second answer choice, a carrier female always has a father with the disease. This is incorrect. A carrier female will have XX and one of them has hemophilia on it. If her father has the disease, he could pass the X chromosome down and this would create a carrier female. But if a father did not have the disease, you could still have a carrier female from receiving an X chromosome from the mom who's a carrier. It's a 50% chance that that would occur. Answer choice C is the son of an affected male can never have the disease. So you have an affected male, he's XY with the X carrying hemophilia B, and then you have a son who's also XY. He's going to receive the Y from dad, so he won't get the disease from dad, but if his mom is a carrier, he could still have the disease. Answer choice D, an affected male and a carrier female have a 25% chance of having a normal daughter. So you have an affected male, he has X hemophilia B and Y, and then the mom has X hemophilia B X, and then they're passing it down to the daughter. The daughter cannot be normal. She will at least be a carrier because of the affected male giving his X chromosome to the daughter. So that question is more helpful if you use the chart to track the genetics being passed down. But as you can see, the genetics are really important to remember that hemophilia is X-linked recessive. And with that question, that is the end of this video.